So today, we're going to finish topic 13. We had a little bit to talk about polio. We have immune disorders to talk about in HIV and AIDS. And I'm hoping to also start topic 14. And maybe when I start topic 14, I'll touch a little bit on the exam. And there will be, of course, some review sessions I'll be announcing sometime next week. Last day, we were talking about polio, and I had basically introduced it as a pretty major fear of people. There were a lot of polio epidemics 100 years ago, 70 years ago, 1940s, early 1950s, and people were in fear of their children becoming paralyzed. And due to some new technologies and a few other kind of circumstances, 2 vaccines were developed, and the Salk vaccine and the Sabine vaccine. And actually, it's a pretty crazy story in terms of these 2 men, in terms of the rivalries and how much they hated each other. And they were working towards the same cause, which was, of course, to eradicate and get rid of polio. So the Salk vaccine, also known as the inactivated polio vaccine, is exactly that. It is a virus that is killed by formaldehyde. And the oral polio vaccine is actually an attenuated weakened lysis vaccine developed by Albert Sabine. So I was just kind of finishing off talking about polio eradication and just showing you some numbers. And you can see this is the situation in 1988. And the good news for, of course, North America, you can see it was actually declared to be polio free. And so the World Health Organization and a few other people, encouraged by their eradication of smallpox, said, hey, what should we tackle next? Why don't we tackle polio? And so you can see the number of cases of polio. This is 350,000 cases of paralysis of children worldwide. So obviously this is something that is really quite terrible. So in 1994, all of the Americas were declared polio free. In 1999, type 2 polio was declared eradicated. So something interesting about poliovirus is it doesn't really mutate that much. And there's only 3 types. So they basically made these vaccine inoculations would have 3 types in it. They were trivalent, you'd call them. And type 2 was eradicated almost 20 years ago now, which is pretty cool. So skip forward to 2002, and you can see that huge parts of the world are polio free, meaning no documented cases. So kind of this leaving to parts of Asia and the Middle East and the African continent as the holdouts. And we'll talk about why there are some issues in a couple of minutes in terms of trying to get everyone vaccinated. So the first question I have is, what makes polio a good candidate for eradication? And I already actually told you 1 or 2 reasons why this is so. One is that you've got a relatively stable virus. In fact, there's only 3 types. And we have vaccines. In fact, we have 2 good vaccines that can get rid of this thing. The third reason, which is also equally as important, is that there's no animal reservoirs of polio. It's not hiding out in monkeys or rats or birds or anything like that. And so it's only humans that have the disease. And so there's no place for it to hide, which is almost completely true, but I'll explain why that is in a moment. I'm not 100% true. So 2012, you can see we've still got a few places in Africa and, that big country over there, China, and kind of the big holdouts at the time were Afghanistan, Nigeria, and Pakistan. And all of those countries have unique reasons why they were some holdouts. But number one is that you're looking at countries with just massive populations. Picture India, for example. India took a while for India to get in Pakistan, because if you think about it, if you vaccinate everybody today, how many babies are going to be born tomorrow? With more than 1 billion people in that area, India and Pakistan, it's very, very difficult. And you've got very remote villages, and there's other epidemics and diseases people are concerned about too. So not everyone is necessarily thinking about polio all the time and getting their children vaccinated. Afghanistan, on the other hand, as you know, today it's still not a stable country with the Taliban and all of the countless wars that have been going on there for I don't know how long. It's really hard to deal with a situation like that when you're trying to go in and vaccinate children. People are not interested. They have more pressing concerns, unfortunately. So question 2 is, why is eradication proving to be difficult? So as I told you, sometimes there's logistical challenges to getting people vaccinated. I haven't really talked about Nigeria. They were put behind for a few years on vaccination campaigns because there was a rumor that the vaccine led to HIV and AIDS. And so the country as a whole stopped vaccinating people. And of course, that put them behind a few years, the rest of the world. And so misinformation is a problem too. But there's one thing that is a huge deal with polio eradication, and that goes back to the actual disease. And I told you before that about 1 in 100 children get paralyzed from polio. So if you think about that, it means for every case of polio you see, there's who knows how many other kids running around, 99 approximately, that have mild symptoms or they're asymptomatic. And so they can potentially spread the disease, and this is a big deal. And so it's a fecal oral kind of disease, and so I mean, if we went and tested our wastewater here, there's a good chance we could find polio virus there. But because everyone's vaccinated, we don't know that. But if you're missing places where people are vaccinated, then there is a higher potential there. There's another issue too I want to talk about in a moment, and I just want to show you some more up-to-date numbers. So type 3 was eradicated a few years ago, so that was exciting. And 2014, India was declared polio-free. You have to be polio-free with no cases for 3 years before you get that certification. And again, a huge story about all the massive amount of efforts going on in India. It's just great job, India. 2015, 74 cases. Again, we've got Pakistan, Afghanistan kind of being the holdouts just due to population and instabilities. 2019, type 3 polio officially eradicated. So this is really exciting. I've been following this for probably 20 plus years, and it's really amazing stuff. So 2020, World Health Organization declares Africa free of wild polio. So Nigeria was kind of the last place to kind of get that certification. So good job there too. So I looked this up the other day, and here is the 2021 numbers. 3 wild polio cases. It's kind of hard to tell how accurate this number is with the COVID-19 pandemic. Surveillance and other things, and of course we've got the Taliban in Afghanistan again, which is making it hard to get the numbers. They're estimating the actual number is probably more than 100, but this is really phenomenal, and we have a really good chance of getting rid of polio sometime in hopefully less than 10 years, which is very exciting. You can see my note there. Without eradication, resurgence of polio could paralyze more than 200,000 kids a year, and that's a big concern. You may notice in the blue there, 560 vaccine-derived cases. So there is a problem with the Sabine vaccine. That's the oral polio vaccine, and that's the one that's given to people in most countries, poor countries, because it's so easy to administer. You just have to tell someone to put this in child's mouth. It's about 1 in a million, I think. But 1 in a million cases, the live attenuated vaccine actually mutates and becomes virulent. And obviously, this is a problem. If you're vaccinated, it's not a problem. But if you aren't vaccinated, now we have virulent polio floating around, and it can hit unvaccinated kids. And so 560 cases have been attributed to that, which is really unfortunate. And this is one of these things that really, honestly, money was a big deal. We've known of this problem for a long time. but there were not any pharmaceutical companies that wanted to invest $500 million into developing a new vaccine. And so richer countries decided they would just go to injectable polio vaccine. And that's what we've been doing in Canada since I don't know what year. I told you I was one of the last generation in Canada to get the oral polio vaccine. The poorer countries decided it costs like a penny a dose, so stick with what you have. And this is actually where the Bill Gates Foundation came in, and Bill and Melinda Gates Foundation came in and said, we're going to spend the money and we're going to help develop a new vaccine that won't do that. And so I believe that's being rolled out in the last 2 years. And hopefully that will not be a problem 10 years from now. So anyway, something to watch. Like I said, I think this is a very interesting situation of some of the success of modern vaccines. Much more to this story than obviously what I said. It's a very interesting story though. Kind of to finish off this topic, I just want to talk about vaccine wish list and things that we would love to have and would maybe solve some of our problems. It'd be great to have a universal flu vaccine. This has been done in mice, I believe, and in llamas. So maybe someday humans will have a universal flu vaccine. And what do I mean by universal flu vaccine? I mean getting one shot, not one annually. Something that works for all sorts of strains. That would be awesome. And we don't have to get the annual jab. What about some of these bacterial infections that plague us? An MRSA vaccine. That would be great. People are working on it. I'm not really sure what the technical difficulties are, but that would be awesome. The major scourges of the developing world. There's lots of neglected diseases. The big ones are HIV, malaria, and tuberculosis, of which all of them have had very tiny amounts of success with vaccines. Tuberculosis, there used to be a vaccine that some of you, if you were born internationally, maybe you've had it. It's not the most effective vaccine, which is why it's kind of on this list. And of course, many other parasite and fungal vaccines would be great to have. So this is kind of a big wish list in terms of what would be awesome to have. And this is a list of things that I've seen in the news in terms of some of the potential vaccines that are in various stages of development, right? I think I mentioned the multiple sclerosis vaccine that is being developed by Moderna with their messenger RNA technology. All of these things, like I said, various stages of development, kind of cool stories. Cancer vaccines, there's actually 2 or 3 on the market now. Which is exciting. That's kind of a different strategy. It's more of a therapeutic approach to a vaccine than preventative. So you get the cancer, then you get the vaccine as opposed to trying to prevent the cancer. And I was even reading about one study of a vaccine being used to treat addictions. Not sure exactly how far that is along the way, but anyway, some very cool stuff. All right, I see there's a question here. Yeah, somebody's mentioning about politics being a problem in her country, and being another polio case. And that is the case, right? There's particularly with polio eradication. I think there's a huge fear that this COVID-19 pandemic is going to set behind the vaccination efforts, particularly in a place like Pakistan. Like I said, you've got kids being born. Lots of babies are born, and anything that puts things behind schedule, whether it's political or logistical, can cause problems. But hopefully we can get rid of polio, because I remember again my mother talking about polio, and she had an uncle that was crippled from it, and she said he was unfortunately disabled most of his adult life, which is really sad to hear. All right, so last part of topic 13, we're going to talk about immune disorders and AIDS. And I'm going to kind of, I apologize if it feels like I'm rushing through this topic. I am just trying to make sure I'm covering the essential things. So if there's something I'm brushing over quickly, it's not going to be that important on the final exam. And I'll try to make it clear to what is important and what is less important as well as we go along with this topic. So immune system disorders, you can loosely put them into 2 categories, a hypersensitivity or an immunodeficiency. So hypersensitivity is where the immune system is reacting when it shouldn't, or reacting more than it should. And there's a whole bunch of names for these kind of things, and they do fall into different categories, but generally, most people call these things allergies or autoimmune diseases. But there are like 4 or 5 types. And it's not going to be important to know the different types. It's more going to be important to know that this is a hypersensitivity of the immune system. And I'll kind of try to tease out some of the details there. Immunodeficiencies, that's kind of the opposite, where the immune system isn't doing what it should. It's not adequate or failing entirely. And there's a lot of scenarios where that's going to happen as well. And the one we're going to talk about the most is going to be AIDS. So hypersensitivities, they are classified into 4 categories. You don't need to know which is which category. Like I said, it's more important just to know examples of hypersensitivities. That's where I want you to be at. Okay, first one to talk about is the big one that probably most people have some familiarity with, is allergies. And allergies are an overreaction of the immune system and to something called an allergen. So what is an allergen? An allergen is basically an antigen that for most people doesn't cause a problem, but for the person the allergy does. And another way to look at allergic diseases as well is to look at the parts of the immune systems that are overreacting. So the IgE and the eosinophils, and particularly the release of histamine. And depending on where in the body this is happening, it can lead to a variety of different types of symptoms, which all fall under the category of allergic diseases. So this includes eczema, anaphylactic shock, asthma, food allergies, hay fever, and all of these are basically allergic diseases. So what kind of allergens are out there? You're probably familiar with some. Everybody knows somebody who's allergic to something, it seems. If it's not you, it's probably somebody you know. People are allergic to pets. They're allergic to different types of foods, different types of pollens, bee stings, all sorts of things like that. And you can see from this little diagram, we're looking at different areas of the body in terms of portals of entry, whether it's injection or inhalation or skin contact and so on. And those can lead to different reactions. If you think about getting something on your skin, usually that's not much of a big deal. You're getting a rash or something like that that's itchy and it's annoying. Poison ivy, for example, some people are allergic to poison ivy, and that sounds terrible, but usually not life-threatening. Whereas if you get something by ingestion or injection, if you have a peanut allergy or a shellfish allergy, and you ingest that food, it can lead to anaphylactic shock, which can be fatal, which is unfortunate. Inhalation, kind of mix and match, but usually that leads to hay fever, sneezing, running nose, and those kind of things. Again, these usually fall into 2 categories. Environmental, here's some, we talked about some of these already. Pollen and pets and animals. And then, of course, sometimes people classify things as food allergies as well, because, of course, we're trying to watch what we eat. And there are some major food allergens. So you can see peanuts are on here, sesame, fish, soy, and so on. So just a little bit of detail in terms of how an allergy works. As I mentioned, we're looking at these IgE antibodies and these eosinophils. And so in order to have an allergy, you must have been sensitized to it at some point. And not going to get into a lot of the details on this, but there is good data to show that if you've never seen the thing, you will not have that allergy. So the question is sometimes where people get sensitized, and we don't necessarily know. But you can see on the left there, there's a mast cell. It's getting sensitized, and now it's producing these IgE antibodies. So of course, on the secondary exposure, the body's getting exposed to the allergen, and now that mast cell is releasing those histamines. And the histamines lead to all those symptoms that we were talking about, depending on the part of the body. If it's inhalation, you're looking at sneezing, running nose. If you're looking at on the skin, it could be itchiness and other irritation. If it's inhalation, you could have trouble breathing, which can lead to severe anaphylactic shock and in some worst case scenario, death. So let's just talk about how we get rid of allergies. Symptoms can be avoided by or alleviated by avoidance. So that one kind of makes sense. If you're allergic to dogs, maybe you don't have a pet dog. If you're allergic to peanuts, you don't eat peanuts and so on. Some we can't avoid. If you're allergic to certain types of pollens, unless you move across the country, that may not work for you. A big one are these antihistamines. So the allergies are activated by histamines. So antihistamines are drugs that block these. So you can see there's the histamines. It's binding to receptors in the body and causing inflammation. And there's the antihistamines blocking the histamines and hopefully alleviating the symptoms. I don't even know how many antihistamines there are out there. The classical one is Benadryl. That one's been around forever. Most doctors are saying avoid Benadryl now because it has more side effects such as drowsiness and those kind of things. There's a lot more newer generation histamines that have less side effects. And I'm not going to recommend it necessarily one over another. Everybody's body is a little different. You can see the last one I have on there is epinephrine. And so epinephrine is basically adrenaline, and that is what is found in an EpiPen. And so anybody who has a severe allergy to usually food allergies or something like that, often they carry around these EpiPens. And it's not necessarily something that is stopping the allergy, but it's basically giving you adrenaline and helping you to breathe. So let's say you have a peanut allergy, you eat some peanuts, and now you can't breathe, right? And so the epinephrine, get that EpiPen shot, puts adrenaline through your body. Adrenaline opens up your breathing passageways and basically buys you, 10 to 15 minutes of breathing. So hopefully that's enough time for you to get those antihistamines or get to the hospital where they're going to give you antihistamines. Because antihistamines, they take kind of 15 to 20 minutes before they actually start working. And so that's what epinephrine is for. So usually I spend a little bit more time talking about the causes of allergic diseases. There is a genetic basis. As I mentioned, you have to be sensitized to them. I used to have a neighbor allergic to carrots. I kind of laughed at him and said, who's allergic to carrots? And it turned out he actually worked in a carrot factory and probably got some of the carrot antigens under his skin while working in the factory, right? It's worth it to talk a little bit about the hygiene hypothesis. As I mentioned before, it's the same part of the immune system that deals with parasitic worms. And so what is the deal with that, right? And it turns out that if you are getting infected by parasitic worms, or that's a part of the world that you grew up in, you're less likely to have allergic diseases. And that's because that part of the immune system is functioning properly. If you're living in a cleaner, more hygienic, developed country where there's no parasitic worms, then there's a good case you're more likely to have allergies. That's kind of what that's all about. Usually I spend a bit more time talking about it, but I kind of don't have time this year. I see there's a couple comments. Somebody's saying, I hear they're getting parents to introduce eggs and peanuts earlier now in children to prevent severe allergies. Is this because they want them to become sensitized early? Yes, very good question. And this has actually been my experience having kids. The recommendation used to be hold off on these things. Tell the child is, at least a year or 18 months, don't feed your child any peanuts. And the idea was to keep the peanut butter or whatever away from the child and they won't get, sensitized. But it turns out that actually made things worse. When they started to look at the data after promoting this for years, there are actually more peanut allergies. And there was actually a really good study where an allergen specialist, he actually went over to Israel and was like talking about peanut allergies. And the scientists in Israel were like, what now? People can get allergies to peanuts? And he's like, there's no peanut allergies here? And they're like, no, not really. It's pretty rare. And so he started looking into this, and it turns out there's these, I can't remember what they're called now, some sort of little snack that people give their babies. They're kind of like cheesies, but they're made out of peanut butter. So there's little peanut snacks, that they give their, like, not chips, but like the cheese, the Cheetos kind of things, but with peanuts in them. And they'll give their babies these things all the time. And so now the recommendation is to feed your child, and particularly if there's a history of food allergies in your family, to try to desensitize your child as soon as possible. And we're starting to see some success from this, which is very interesting. Anyway, like, there's a lot of information on this. I'm not going to go into all this anymore, but it's highly recommended now anyway, particularly when there are peanut allergies or other food allergies in the family. So I just want to kind of finish off on allergies, talking about this one here, because this was in the news quite a bit when it happened, and it was on at least a couple of TV shows. They were talking, this guy, Californian resident, had these severe allergies to the point where he couldn't even hold a full-time job. And he'd read about this hygiene hypothesis kind of thing, and he was like, well, I'm going to go get myself some parasites. And so he he went to Cameroon and he got himself infected by hookworms, and his symptoms went away. And there's lots of anecdotal stories like this about people getting infected with parasites, and this exactly happening. He was trying to sell his hookworms over the internet. I think he got in trouble for that. Hookworms, if I were to choose a parasite to infect myself, it wouldn't be hookworms. Hookworms can make you anemic. But there are people looking into this kind of thing to figure out if there's some way we can, maybe not infect someone with a hookworm, but maybe there's a molecule, involved on the hookworm that we can put in a pill or something someday. It's very slow progress. Probably because the immune system is so complex, but maybe someday we'll be taking, hookworm pills that don't have live hookworms, but maybe have hookworm antigens. We'll see. All right, so there are other types of hypersensitivities out there. I'm going to just quickly go through some of these. And like I said, you don't really need to know which is type 2 versus type 4. Just know that these are hypersensitivities, and they are classified differently because they're activating different parts of the immune response. So part 2 is cytotoxic hypersensitivity, and this is basically where the immune system is recognizing something as this is not me. Examples are if you get a blood transfusion and it's the wrong type, that's very bad. The immune system will go crazy, and that can lead to death. Also, hemolytic disease of a newborn falls into that category. That's where the fetus has a different blood type than the parent and can lead to some issues in some pregnancy cases. Type 3 is immune complex mediated hypersensitivity. These ones here are often called autoimmune diseases, and there's a whole bunch of examples of these. And rheumatoid arthritis is maybe the most common and well-known one. And this is where usually something gets into the body, causes an immune response, and then it just kind of escalates and gets worse. So I think I have some pictures of rheumatoid arthritis here, kind of what's going on. So you can see we've got a little bit of damage here, and we've got some immune cells coming along and trying to clean up the damage. And as part of that immune response, they cause more damage, and it just kind of escalates and gets worse and worse over time. And this is kind of the problem. And so, like I said, there's a bunch of these things. Farmer's lung, I don't know a lot about farmer's lung. I imagine they're getting exposed to something. I'm not sure if it's hay dust or what it is, but it's causing some issues with the farmer's lung. And lupus is another example of those. Here's a cartoon of rheumatoid arthritis. It's really hard for me to look at actual photos of this actual thing until some severe cases where you can see the joints are inflamed and in many cases causes, the warping of those joints. And these people, in some cases, have a hard time doing simple tasks like buttoning up a shirt or something like that. I think we've got an X-ray or two here. Here's a normal hand on the left and someone with rheumatoid arthritis on on the right. And then the last group are also called autoimmune diseases, and there's a whole bunch of these out there. The difference between type 3 and type 4 is the delay, and like I said, different parts of the immune system getting activated. So you can see multiple sclerosis, that's where the immune system is attacking myelin sheaths in your nerves. Crohn's disease is more in the gastrointestinal area. Type 1 diabetes is where the immune system is attacking the pancreas, and so on. And like I said, there's a whole bunch of these, and these are getting a lot more press and news lately because we're starting to understand a little bit more about these things, and hopefully for some of these things we can get some treatments eventually. Okay, so kind of the last footnote on this is that there is a connection between some of these autoimmune diseases and infectious organisms. And some of these things are not really that well understood. Obviously, for autoimmune diseases, there is a genetic aspect. Some people are genetically predisposed to type 1 diabetes, for example, which is why it usually has onset in childhood. But it seems that there's kind of this association with getting infected by certain benign viruses, usually benign in most people, that leads to that progression of diabetes. We're still trying to work out and understand how this works. But here's like 3 diseases, like I said, that there seems to be some association with the onset of these diseases and certain infections. And like I said, these are things that we're still trying to tease out and understand, but they're kind of interesting little tidbits of microbiology. Okay, so let's talk about immunodeficiencies and talk about AIDS. We classify immunodeficiencies into 2 categories, primary and acquired. So primary means you're born with it, right? So some sort of genetic disorder. There's actually a whole bunch of primary immunodeficiencies out there. Some of us may have it, and it means that some part of your immune system is compromised in some way. So sometimes it means there's some issue with your B cells or a small issue with your T cells. And in many cases, people don't actually know what the problem is because there's so many overlapping redundancies in the immune system. So if you have small problems with your B cells, your T cells are good enough to give you a strong immune response. It might just mean you get certain infections more often. Maybe you get colds a lot more than somebody else or something like that. And so in many cases, these things aren't well documented. There's one very famous primary immunodeficiency, which is once in a while you hear about it in the news. It's called SCID, which is severe combined immunodeficiency syndrome, or the bubble boy disease. And this is where the body is not able to make lymphocytes at all. So no adaptive immune response entirely. And in many cases, this is kind of a fatal condition, or the person has to live literally in a bubble, isolated from everything. And this was made famous by a movie. I think the movie was even called The Bubble Boy or something like that. And this was one of the cases, this boy here, David Vetter, that was studied in quite a bit of detail. Oh, there it is. There's the movie, The Boy in the Plastic Bubble. I haven't actually seen this movie. It stars John Travolta. I just remember my sister talking about it a lot. I think she's in love with John Travolta. So he was playing the part of David Vetter. Acquired immunodeficiencies are the opposite. These are things that you're not born with, but can be caused by certain circumstances. So just general poor health, which could be due to malnutrition or advanced age or severe stress. Those kind of things can take a toll on the immune system. And certain chronic diseases such as cancers or surgeries or chemotherapies. There's all sorts of categories that fit that. And then what we're going to talk about in some detail is infection with HIV. But there are other diseases that can actually knock out the immune system. Measles is a big one. Measles actually will kill memory cells specifically. So it's kind of like giving your immune system a reboot, which is kind of scary. And in some cases, people get severe secondary illness from measles because their immune system has just been, like I said, think of just your immune system getting an entire reboot, all your memory cells just wiped out, and then you have a problem. So let's talk about HIV and AIDS. We did a little bit already, and we want to kind of focus a little bit more on the AIDS part today rather than the virus part in terms of what is going on. So what is AIDS? AIDS stands for Acquired Immunodeficiency Syndrome, and there is a clinical definition of AIDS, and this is kind of it here. So you can see it's this here group of symptoms and diseases associated with a decreased amount of CD4 cells. So CD4 cells are actually a certain type of T lymphocyte and the presence of the HIV virus. So if you are HIV positive, it does not mean you have AIDS. But if you don't get treatment for your HIV status, you will most likely eventually get AIDS. AIDS is a certain point where your immune system is so broken down that you can't fight off some basic infections. And we'll get to some of the progression of AIDS here in a couple of minutes. What are these symptoms and diseases? This is something that sort of changes from time to time and may actually be different depending on your geographical location as well. I'll talk about that in a moment. But some of these diseases include things like shingles. So shingles is a reactivation of the zoster virus that normally causes chickenpox. Herpes viruses, so herpes simplex, but getting it kind of in different body parts, rare cancers, fungal infections, and all sorts of rare infections that normally don't infect healthy individual. So like I said, progression of HIV infection usually leads to AIDS without treatment. So here are some of these diseases, some kind of horrific pictures. One is disseminated herpes and/or shingles. So if you remember herpes, usually there's all those herpes viruses, but there's herpes simplex 1 and herpes simplex 2, and then shingles is caused by the zoster virus, which is also technically a herpes virus family, herpes family virus. And disseminated means it's not just in one spot, but spreading to several parts of the body, and so that looks quite terrible to have. Certain types of rare cancers. This one is particularly common against AIDS patients. Kaposi's sarcoma, which is cancer of the blood vessels. So normally this type of cancer, I guess, is fought off by your immune system, a healthy immune system. Pneumocystis, that's usually refers to fungal infections of the lungs. Tuberculosis, not necessarily in Canada, but if you are, for example, in certain parts of Africa and Asia and you get tuberculosis, often the very next step is they test you for HIV. Because there are a lot of people in some parts of the world that have latent tuberculosis, and it only gets activated when their immune system gets beaten down. And so that is often a diagnosis in some parts of the world. Thrush, there's another one that normally it's not affecting usually healthy people, but people with HIV, their normal microbiota can be all messed up. So back to just a reminder about HIV. HIV is, of course, the virus. It stands for human immunodeficiency virus. It is a retrovirus. That means it's an RNA virus, and its RNA is going to be made into DNA. And it has these glycoproteins here. So we have glycoprotein 120, and that's what actually attaches to those CD4 cells. And those are a certain type of T cell, which are actually helper cells, part of the regulation of the immune process. Here's kind of a quick recap of the HIV life cycle. You can see we have the very first step there is we have this glycoprotein binding the CD4 receptor on the cell. The virus fuses with the membrane, and there's the genome here. The genome here is RNA, and it's getting injected into the cell. And if you remember, one of the unique things about HIV is it has this enzyme called reverse transcriptase. And the reverse transcriptase takes single-stranded RNA and makes it into double-stranded DNA. And then that DNA enters the nucleus. And here it is entering the nucleus, becomes a provirus. It's integrating into the genomic DNA of the host cell, so it becomes a lifelong infection. And then eventually that DNA gets induced, and you can see we're making some viral RNA here. The viral RNA makes some viral proteins, and eventually you get assembly of the virus over here. And that's kind of the very basics of the HIV life cycle. So I won't be asking you about the HIV life cycle on the final exam, with one exception. I may mention the enzyme reverse transcriptase. I could see there being a question about that somewhere. So here's a picture of the HIV virus budding from an infected immune cell. And as mentioned, these immune cells, of course, are essential for a proper immune response. And so if you are killing cells involved in the immune response, then you're affecting your immune response. And this can lead to a general failure of the immune system, the adaptive immune system anyway. So let's talk a little bit about the epidemiology of HIV. So take a look at this. This is kind of weird. If you look at where the virus is found, the most amount of virus is found in the cerebral spinal fluid. Turns out this is not a risk for infection. Usually we're not sharing our spinal fluid with other people. It's pretty well protected. So in terms of what is the most important for HIV transmission are actually two other bodily fluids. Our plasma, that's the blood plasma, and semen. Those are the highest risk areas of transmitting the HIV virus. So this means activities that are sharing seminal fluid or blood are going to be the highest risk activities. So really we're talking about, for the most part, sex and drugs are the highest risk activities for spreading the virus. You can see there is a little bit found in breast milk, a little bit found in saliva, a little bit found in tears, ear secretions, those kind of things. Generally lower risk activities. Whereas when we're talking about sex and drugs, we're also looking at activities that are higher risk of causing abrasions and bleeding and direct access to somebody's bloodstream as well. So we'll talk about transmission of this as well. I guess I talked about this already. Transmission includes sexual activities, blood transfusions, which again is a lower risk activity because we do screen our blood for HIV, but it is possible. Prenatal, childbirth, breastfeeding, those kind of things. And a lot of these things, such as childbirth and breastfeeding, these things can be dealt with. We can bottle feed the child, and during childbirth, there are ways to try to prevent transmission as well. So in terms of the epidemiology, this is where it gets kind of interesting when we start to compare different populations. If you look at, and this is true for Canada and the United States, if you look at males getting HIV, a big chunk of that is males who are involved in male-to-male sexual contact. 15% heterosexual contact, and then injection drug use is the other big group. If you look at females, the majority of cases of females getting HIV is from heterosexual contact, and then the second group is injection drug use. So, like I said, in terms of the risk of activities, you are looking at activities that do expose access to the bloodstream, of which a male-to-male sexual contact is a bit higher risk for men. So something else about the epidemiology of this is if you look at the amount of virus found in somebody's blood plasma. So this is the kind of interesting thing. You can see here in the first few weeks of infection, so right over here, this is where the virus is actually found at the highest concentration. So what's happening is the virus is infecting the person, and it's starting to multiply, and usually somewhere by the 10-week mark, the person is mounting an immune response enough to keep the viral load at kind of this basic low level. So it turns out that the highest risk time for somebody to infect someone else is when they're newly infected. You can see that the viral load actually does go up kind of near the end, but at this point, we're looking at somebody that probably has advanced AIDS, and they're less likely to be it's possible, but they're less likely, people know they're sick, and so they're less likely to have sexual contact with them and those kind of things. Now, the one thing to keep in mind is that, if you're living with someone and it's a spouse or something like that, even, at these low levels of virus, there is a risk. And so sometimes it's just a matter of time before the infection does spread to the other individual. But this area here, first few weeks, that's when the person is most likely to infect someone. And in some cases, they don't even know they have the virus, unfortunately. Here's the other thing I wanted to show you, which is very interesting, is when you look at worldwide what is going on. In the USA and Canada, this is kind of the big groups. Like I said, male to male sexual contact, heterosexual contact, and intravenous drug use are kind of the big categories. And you probably know that if you know a little bit about HIV. And of course, kind of going back to some of the conversations we had before, how does this affect prevention strategies? Well, there's, we have all sorts of programs where we're, advocating condom use for youth that are involved in sex behavior and of course, any risky sexual behavior. In particular, there's lots of marketing and information towards homosexual contact for people that are doing that kind of thing. And for injection drug users, we have things like needle exchange programs and trying to educate people. And we've done a decent job in terms of kind of keeping the transmission of HIV down to a certain level in Canada. We can always do better, of course. But here is where the shocking thing is when we look at worldwide what is going on. And worldwide, most HIV transmission, at least 2/3, is heterosexual contact. And this is something that people, often people who grew up in Canada, have a hard time understanding because, we're so used to thinking about the riskier behaviors, drug use, and like I said, male-to-male sexual contact. And part of it, it's just really hard to explain why this is the case, because everywhere you go in the world, you're looking at different issues. And so let me just take a look at this next slide here for a second. Let me just give you a brief story. I was watching an interview with an epidemiologist, and she was studying HIV and AIDS. And she was talking to a guy who had AIDS or HIV, and he had gotten it in prison. And he was telling her a story about how one day it was somebody's birthday, and somebody had smuggled some heroin into the prison. And the guys were hanging out, and there was heroin in a needle. And the first guy injected himself and then wiped the needle off on his shirt and passed it to the next guy. And he's looking and he's like, I'm number 5 in this line. And he had 2 thoughts going through his head. His first thought was, dear God, there could be, I could get HIV from this because, that needle's not getting sterilized. But his second thought, and even more powerful thought, because he was addicted to the heroin, was that I hope there's enough left for me. And this is kind of the story about HIV and AIDS, in that, people, when it comes to sex and drugs, people do not think clearly. And they're very complicated issues in terms of, what is normal sexual behavior, what is permitted worldwide, and even looking at in terms of what is normal between men and women in different countries. There's very, very many complicated issues. And I'll maybe touch on that another story here in a moment. This is kind of the map I showed you way back at the beginning of the semester, mentioning that if you take a look here in the African continent, there are a lot of countries where the prevalence of HIV is much higher, much higher than what we'd see in Canada, and to really a shocking extent. So I want to show you just kind of this little model about HIV transmission and kind of mention what's going on with some of these countries in terms of why it's a little bit higher. If you take a look at this, the top model, serial monogamy, is usually the norm in a place like Canada. So what does that mean? It means usually we're with one other sex partner. Sometimes you break up and you move on, or you get divorced and you get remarried, or whatever. But usually it's one person at a time. So if you break up and you find someone else, it's not all at the same time. Is what I'm talking about. So if you take a look at here, right? Here's somebody who gets ill for some reason, and he or she infects his or her partner, and often that's it. That's the end of the line. Both people, maybe they get treatment, or they realize their HIV status and try to prevent spreading to others. Concurrency is where there's a big problem. And so you can see with the concurrent model here, this person here, this male, gets the HIV virus, infects a female partner, and that female partner has another sex partner, and that sex partner has a couple other partners, and it's kind of like this big web of, holy cow, look at all these people who got ill. This is been talked about a lot for at least 20 years now. If you want to really read some good stuff about it, you can check out this book here. It used to be in the Canada Library. I'm assuming it still is. And it talks about some of the issues that's going on in particularly parts of Africa, right? And for example, she's talking about South Africa, which is kind of like Fort McMurray. It's a mining area, and you've got all sorts of migrant workers, and she talks about these scenarios where you have, let's say you've got a man who leaves his wife and family often in another country, and he moves to South Africa for work. And when he gets there, he's lonely and finds a female companion, and maybe he doesn't have enough to support her, but maybe supports her a little bit. And it's not prostitution. It's sort of more of people are doing this out of need, but she can't get enough support from him to fully pay the rent or pay her, phone bills or whatever, and finds other companions, and so you get this web of things going on. Never mind, because of the migrant workers, there's also a lot more people engaged in sex work and prostitution, and these are opportunities for this concurrency to work. Like I said, if you want to read more about this, you can check out this book. She also talks about, for example, a certain group in I think it was Kenya, where polygamy is pretty common, and sometimes there's wife sharing, and this particular group has a higher rate of HIV than groups that don't do that, for example. And I mentioned that story because a few years ago I had a student who had mentioned that particular item, and she said, hey, you know what, my grandfather had 5 wives, and she was from Kenya, and maybe from this particular group. I'm not entirely sure, but I thought that was kind of interesting. Now, I'm not saying that all Kenyans are like that. I'm just saying it was talking about this one particular group, and that had a high HIV positive status, and they believe that was the case with the spouse sharing, seemed to be the most likely issue. So some of the last things to talk about with HIV is treatment and prevention. And one of the things that can or may be an issue for you as a healthcare worker is how to protect yourself. And so nowadays, usually what happens is most HIV patients would be declaring their status. And so if you're a dentist or a nurse or a doctor, there's extra precautions that go into trying to protect the healthcare workers, right? So things like extra gloves and goggles and face masks and those kind of things, and extra careful handling of sharps and whatnot, which is usually the case in general. But you go a little bit out of your way when you're dealing with someone with HIV, just to make sure that you're not having any elevated risk to the healthcare workers. Washing up those kind of things. And sometimes there is accidental exposure. And needle stick injuries and things like that do happen once in a while. And the typical thing to do is treat the healthcare worker aggressively for several weeks with antiviral drugs, hopefully killing the virus before it gets a chance to really give infection, and then monitor. Because at the moment, that's all we can do. There's no vaccine for HIV. All we can do is, try to hit it off at the pass. And there's been some success with this, although, like I said, once in a while there are cases of people getting infection through healthcare settings. I'm not sure what the stats are like, but it is pretty rare nowadays. I just want to talk a little bit more about the progression of HIV. And I had showed you this chart here showing in terms of what the viral load looks like over the progression of an infection. And so this is looking at and assuming the person is not getting any treatment. So the viral load is high initially. After a few weeks, they start to have an immune response and the virus levels are kept low. But as it goes along, the virus is killing immune cells. And eventually, the average is about 8 years, there's a point where the immune cells, their numbers are just too low to be able to keep fighting off that infection. And so the viral load goes higher. But let's talk about what's going on with the body, and particularly these immune cells. So if you take a look at this here, right, CD4 T cells, that's what the virus in particular is killing. So you can see initially it's destroying them at a pretty high number. And slowly over those 8 years, the numbers of those CD4 cells are decreasing. And eventually they hit this threshold where we're looking at really hard time having a good immune response. And so I want to just talk a little bit about the progression of symptoms as well. I think I've got a chart here to show you here in a moment. So there's the numbers, right? Without antiretroviral therapy, the life expectancy is about 9 to 10 years. I thought I had something else here. I know I have in your notes and in terms of what is going on here. And usually I have my notes with me, but I don't have them today. So I'm going a little bit off of memory. Maybe let's just talk about what's happening here in these first few weeks all the way to the 8 years. These first few weeks, the person has something that looks a lot like infectious mononucleosis, so mono. And so you're looking at things like fatigue and fever and swollen lymph glands, because of course the lymph glands are where the immune response is happening pretty vigorously. And then it goes away, right? Like I said, after a few weeks, that's kind of the typical symptoms. Usually this section in the middle is asymptomatic, meaning the person doesn't usually have too many infections, sometimes a few more than usual, but nothing usually that raises the alarm. And then this last stage, eventually there's a point where when the CD4 cells get to 200, so this level here, we would call this here AIDS right here. And that's the level we're looking at when we're talking about clinical AIDS. Before that, it's called pre-AIDS or pre-AIDS symptoms. I can't remember the exact term. And this is where you're starting to get all those weird and rare infections. So the disseminated herpes, shingles, various types of rare cancers, tuberculosis, etc. There's all sorts of things, a huge, huge list, of which I have some of them listed in your notes. Here's some of the infections, and you may recognize some of them here. Toxoplasma. I think I mentioned way back when we were talking about toxoplasma. That's the organism, by the way, that's spread with cat feces. And initially, early on, when HIV and AIDS became a new thing, they were getting infections of latent toxoplasma causing issues. Now it's less of an issue because if someone has HIV positive, usually they kind of get treated for that kind of right away. But all sorts of organisms here. You can see tuberculosis I mentioned. There's a non-tuberculosis mycobacterium that is found in your shower head, by the way. Mostly it's not making anybody sick unless you're immunocompromised, and that's where it becomes an issue. You can see all sorts of fungal species can cause issues, and there's our herpes viruses there as well that are sometimes causing issues. So there's that number, by the way. Like I said, usually the clinical diagnosis means, when they look at the blood, there's less than 200 of those CD4 cells per microliter of blood. So how do we diagnose HIV? As I mentioned a couple of times the last few weeks, usually the amount of virus in the blood is small and hard to detect. And so we're actually detecting antibodies against HIV. So we're looking for an immune response. And there's different methods. There's an ELISA test usually, or there's that rapid test. And usually, if that's positive, they follow it up with a secondary test called a Western blot. That's also an immune test. And I'm not going to get the details on how Western blot works, but it is more sensitive than the ELISA. And so it's kind of like a backup test, just to make sure. Sometimes you do get false positives or false negatives, depending on the reliability of that particular test. So how do we treat HIV? Well, nowadays, this is something that has been really evolving like crazy over the last couple of decades. In 1990, I think it was, we came up with the first anti-HIV antiviral drug. There was a problem with the virus, is that this virus, you can see here, it rapidly mutates. How fast does HIV mutate? Super fast. It mutates in 1 month in the same amount that the flu virus mutates in a year. So this is like more than 10 times faster than the flu virus mutating. And the other problem is, so what you're looking at is getting all sorts of, like in one human, you have many mutants and variants and whatever you want to call them. And so one mutant may actually gain resistance to a drug. So what we do now is we use these cocktails. They're called HAART. Stands for highly active antiretroviral treatment. You can tell this was named by a pharmaceutical company, the marketing division, I'm sure. And what they do is they throw a cocktail at the virus. And usually you're looking at about 3 different drugs. There's different formulations in terms of, what the current data is showing and whatnot. And like there's always new drugs coming out. And so sometimes they're looking at what is working for one person or less side effects and those kind of things. But it usually includes a variety of different types of drugs, some that we talked about. So those nucleoside analogs, remember they look like nucleotides, protease inhibitors, reverse transcriptase inhibitors. And so you're trying to hit the virus on multiple fronts so that if it does have a mutation that prevents it from being killed by one type of drug, then the other type of drug will hopefully kill it. And these treatments are quite effective. We're at the point now where there are people that are in their 30s and they have been HIV their entire life, HIV positive their entire life. They're born with it, and they're living somewhat normal lives. So this is very effective. Long term, I don't know what it's going to mean for these people in terms of side effects and those kind of things. Some of the drugs have had some severe side effects in the past. We have a lot better drugs now than we did in the 1990s. Like I said, this seems to be highly effective type of strategy and treatment. Okay, so let me just do a time check. All right. So what about an HIV vaccine? This is worth talking about for a minute. There's 2 main targets, these glycoproteins. So just like the coronavirus, we're looking at proteins, spike-type proteins that are found on the surface of the virus because that's what the immune system is going to attack. And so this is where the focus has been on HIV vaccines. So one big problem, this thing mutates. And so this is where the problem has been. There's been quite a few actual trials of potential HIV vaccines, and nothing has really shown the type of success we'd like to have. The virus is very good at, well, it's crippling the immune system. And so it's very good at evading the immune response and it's disabling the system that is mounting immune response against it. So this is a big deal. We're trying to, there's been a lot of progress in understanding the immune system in the last 10 years. And there's questions in terms of maybe we need to have new strategies. I think Moderna as well is looking at the HIV problem, and their thought is that you maybe the next step in HIV treatment is custom vaccines. So you isolate the virus from that individual and you make a messenger RNA vaccine that's targeted to what strain that person has, and maybe you have to change it up every few years when the virus starts mutating. We don't know, but there's lots of people working on this, and maybe someday we'll have a chance to save millions by having an effective vaccine. Okay, I already said that about one effective vaccine. Here's a number for you, right? If you take a look at how many people are infected on the planet and how many viruses they might have in their bodies, there's 10 to the 16 genomes of HIV. And the virus is going to be resistant to every drug we'll ever have, ever. And so if we can ever figure out the vaccine thing, it's going to be a big deal for people with HIV. So last footnote about this, is there a cure? It turns out there is a cure for AIDS, HIV. And as to my knowledge, there's 2 people who have received this treatment. This was a few years ago now. This guy was initially known as the Berlin patient. They were keeping his name anonymous, and his name is Timothy Brown, and he decided it was too important to keep himself anonymous, and has been talking about this for a few years now. And so this guy had leukemia, and ended up getting what happens when you get leukemia. Sometimes you get a bone marrow transplant. So think about that for a second. A bone marrow transplant is actually an immune system transplant, right? Because that's where your immune cells are made. So in this case, when they found a compatible donor, there was also another rare thing that happened. So it turns out, I think it's about 1 in 100 people out there are naturally immune to HIV. There's something going on in their CD4 cells, a slightly different antigen or something like that. I'm not sure of all the details there. So in this case here, this man was lucky enough to have found a donor that was compatible with his bone marrow, plus also that donor was naturally immune to HIV. So he got the transplant and eventually went off the retrovirals. A lot of people do because of side effects. And he's been living for years without the virus. And there was a second patient now that the procedure was done on, called the London patient, and also with the same kind of success. So why are we doing this more? This is a very complex, difficult, expensive procedure. It's just really not practical to do this for every person on the planet with HIV. Maybe someday there will be a system for doing this more efficiently, or who knows? Maybe there's some sort of genetic engineering solution and whatnot. And lots of people are certainly thinking about this because there is a potential solution. So maybe we'll hear more about this in the future. I think it's exciting. I always love to hear about stories about disease eradication, and that would be pretty cool to get rid of this one as well. So like I said, this is a complicated issue. If you ever see the red ribbons, it's people who are supporting HIV/AIDS research. Like I said, on one hand, it just seems so simple we can get rid of this virus by practicing safe sex or not doing drugs. But like I said, a lot easier said than done. Sex and drugs are very complicated issues. And particularly everywhere in the world, there's all sorts of different norms and different acceptable practices and whatnot. Very, very complicated stuff. Okay, so I would love to talk a lot more about AIDS and HIV. I think it's a very fascinating topic, but we're going to have to move on. Got about 10 minutes, and I kind of want to just start getting into topic 14. So let me just load that up here. And we'll get that going. All right, just give me a second here. I'm going to pull that up. There we go. All right, I think that should be on your screen now. So topic 14, if you've printed it off, you know it's a beast. I can't remember how many pages it is. It goes on forever and ever. But don't fear. Topic 14 is kind of about 2/3 of it is review. So a little bit of this is getting you ready for the final exam. And there's a few things we're going to kind of flesh out a little bit. We're going to talk about diseases of the body system, and I'm going to remind you of some of the pathogens we've been talking about all semester. In some cases, I'll give you some new information. In some cases, I'll talk about some things we haven't really talked enough about, like tuberculosis. We're going to talk a little bit more about. We've sort of been, talking about here and there. I want to sort of put it all together in one area and talk a little bit more about tuberculosis as well. So today we might do part 1 or maybe part of part 1. And then over next week, we'll get through the other parts and cover some material. So one other thing to keep in mind is that I do have a few things in the notes that are, mentioned very, very minor capacity. And like I said, I'll try to be clear about what is important as we go through this. If I'm mentioning like a disease once, like I'm going to talk about cat scratch fever, I'm not going to ask an exam about cat scratch fever. I'm just talking to you because it's given an important example at a certain point in this lecture and so on. But other things that we keep talking about again and again: Staphylococcus, Streptococcus, E. coli, tuberculosis, all these things we're talking about again and again and again and again. So make sure those are the things that you are focusing on when you talk about the final exam. I'll come back again and talk more about the final exam next week, of course, and I'll announce when the additional review sessions are going to be for anyone who's interested in doing that. And one thing that you can do right now is you can take a look. I put some quiz questions on Moodle for the final exam that maybe will help you with your studying. So you can check that out anytime you want. All right, so infections of the human body. Part 1 is infections of the body surface. So mostly we're talking about the skin. The skin, of course, is the first line of defense. We're just talking about it having, it's salty, it's got sebum and low pH, and of course there's your normal microflora that are protecting you there. And so mostly we're going to be talking about skin infections here in this particular unit. There's also the conjunctiva, which is the lining of the eye. And so if you get an infection there, it's most people are calling it pink eye, although the technical term is conjunctivitis. And if you take a look at, you're going to see for all of these diseases we're going to talk about that there is a list of organisms that are potential causes. And in many cases, you're going to see a lot of the usual suspects. If you take a look, for example, at conjunctivitis here, I think we've talked about, let's see here, we've talked about gonorrhea. We haven't talked about chlamydia yet. We've talked about staphylococcus. We've talked about streptococcus. We haven't talked about Haemophilus, and I'm not going to talk about Haemophilus, but you're going to see it's going to pop up again and again in these notes. We talked about Pseudomonas briefly. We're going to talk about a bit more possibly today. Talk about herpes simplex. So like I said, you're looking at a lot of the same usual suspects. And in some cases, there is one that's kind of usually the cause of it, but there in many cases, when we're looking at some of these diseases, there are multiple possible causes. So just something to keep in mind. So what are the usual causes of skin infections? Number 1, Staphylococcus. Here's our two main Staphylococcus organisms. Staphylococcus epidermidis can cause skin infections, but the big one, the one that is the biggest problem, is usually Staphylococcus aureus, and these are both gram-positive cocci. There's another organism that comes up once in a while, this one here, Propionobacter acne. I'm not going to talk about it here today, but it's usually the cause of acne. So if you have acne problems, that's kind of the problem. And it's also gram-positive. And I want to talk about one important gram-negative organism, which is Pseudomonas aeruginosa, which is an organism that has a bit of a special place in my heart because I did research on it. And although in my heart is kind of not quite the right way to say it, because it is a nasty, nasty bugger. And we'll talk about that probably a bit too next day. And I see there's a quick question here. It says, will these reviews be offered online for people who aren't in Fort Mac or in person? So good question. I'm going to do both. My plan is to have 2 or 3 review sessions. So one will be in person only, one will be online only. And I haven't decided what the third one will be yet in terms of the format there. And that way it gives everyone different options for attending the review sessions. But good question, thanks for asking. Someone's asking about COVID being a pathogen, not of the skin. I don't know if that's your question. We will get to COVID-19 when we talk about respiratory infections. Oh, for pink eye, that's a good question. It seems to be giving all sorts of issues, but I'm not sure usually if it's considered causing eye infections, but it could be. I'm not sure. Maybe we should look into that. All right, so let's spend, looks like we got about 5 minutes left here, and we'll probably spend most of that 5 minutes talking about Staphylococcus aureus. So just a reminder, if you don't remember what it is, when we've been talking about all semester, it is Staphylococcus. So it's spherical in shape, found in clusters. That's what Staphylococcus means. Aureus means it's golden. So when it grows on a petri dish, it has a gold color. Excuse me. It's catalase positive, coagulase positive. And Staphylococcus is one of these organisms that is, it's really good at infecting almost every single body system we have. Like you name it, the skin, blood infections, there's staphylococcal pneumonias, it can cause meningitis, and it's just really good at infecting multiple body systems. And this is because it has a lot of virulence factors. So if you remember what a virulence factor is, it means something that's allowing that pathogen to be a pathogen. And so here's a bunch of examples. It's salt tolerant, that allows it to live on your skin. It can form slime layers that protects it from the immune system. It often carries a penicillinase, that's an enzyme that destroys penicillin, so it's naturally resistant to some drugs. Has all sorts of tissue destroying and invading enzymes, such as destroying blood clotting proteins and things like that. So it's really, really nasty in some ways. In terms of epidemiology, it can live on your skin. It likes a little more moist places, so around the nostrils and armpits and things like that. It tends to like a little bit more moisture than Staphylococcus epidermidis, and it can be spread by direct contact or spread by fomites, so doorknobs, you name it. So very easy to be spread all over the place. And what else can we say about it? And it can frequently infect surgical wounds, IV line incisions, catheters, like I said, you name it. It is in a hospital. Staph infections are a little bit of a nightmare. And in particular, it's quite nasty if your immune system is not great, which means a lot of people in hospitals, particularly old people and newborns, it can be more scary, or people on chemotherapy, which is obviously something we don't want. And I threw this number here, I think, before. About half of the hospital-borne infections, nosocomial infections, are caused by Staphylococcus aureus, and a quarter to a half of those are caused by MRSA. So let's talk about MRSA, because this is the one that is kind of like your worst nightmare. So MRSA technically stands for methicillin-resistant Staphylococcus aureus, although I'm starting to see in the literature more people are calling it multi-drug resistant, which is more accurate to what this organism is. Methicillin, by the way, used to be the drug of last resort. So when we said something is methicillin resistant, it was kind of, okay, well, that's scary. But multi-drug resistant is a little bit more accurate to what we're looking at. So this is something that we're very concerned about. And as I mentioned before, in hospitals, when this kind of thing happens, we're taking it seriously. We're isolating the person. Guests have to wear gowns. Depending on the hospital, there's different procedures, but they're trying to keep that person away from infecting anybody else. So what are some of these infections? If we look at skin infections, we're looking at folliculitis, which is infection of hair follicles and boils, or when you start getting more pus in there. And so, you know, this is sometimes it's called a sty if you get one in your hair follicle, your eyelashes, and those kind of things. And so they can be uncomfortable and not look pretty. You can get deeper infections called impetigo, which is kind of just a little bit more under the skin. This is a bit more common in children for some reason. I don't actually know the answer to that, why that's the case. But one of the common things is to have a rash on the face. Doesn't have to be on the face, it can be on the hands, those kind of things. And this is usually caused by Staphylococcus aureus, but sometimes caused by Streptococcus, as you can see on the list there. Staphylococcus aureus and Streptococcus being kind of the main two suspects. And you know, usually you're looking at having to get antibiotics to treat this. There are all sorts of skin infections caused by Staphylococcus. Scalded skin syndrome is another one. This is caused by some strains that have a certain toxin that actually kill the outer layers of the skin, and a bit more common in hospitalized patients that are immunocompromised. So like I said, there's a whole bunch of these. I keep reading about them. I can't even keep track of all of them. Here's another one. This one has a big acronym, right? Pvl Mrsa. This one is a bit more common in community isolates, and it has often these acronyms are describing some sort of toxin or some sort of genetic aspect of that particular strain. And this one has a toxin that I can't remember what it does, but somehow it's killing the cells in those tissues and leading to these sort of darker blisters or lesions or whatever you want to call them. Okay, just bear with me. I'm going to finish up here right away just on Staphylococcus. Another thing that can go from those skin infections is working towards blood infections. And the blood infection that we talked about was toxic shock syndrome. And I mentioned that this is due to a certain antigen. We call this a super antigen that's found in Staphylococcus aureus and sometimes Streptococcus, and can stimulate a massive immune response. So this is from the infection getting into the blood. So how do we diagnose this? Usually Gram stain followed by biochemical tests. So the Gram stain is going to show Gram positive Staphylococci. The biochemical tests, we're looking at like the catalase test and things like that to determine that it's Staphylococcus aureus. And then treatment is, well, often using different types of drugs. Methicillin used to be the drug of choice. I'm not sure if it still is. I think this is the type of thing that the drug of choice changes on a regular basis because different studies are showing different strains are going around. But in some cases, people are getting multiple prescriptions if they do have a drug-resistant version of it. And this is where it gets very, very difficult. All right, so I think that is it. What is the prevention? People need to keep themselves clean, and we need to be, like I said, in terms of patients that have MRSA, we need to be making sure we're keeping them clean and away from other patients and all those kind of things. All right, I just see there's one more comment here going back to the pink eye. Someone's mentioned COVID eye, so just to sort of follow up on that, the SARS virus isn't infecting the eye, but it's leading to symptoms all over the body. So it's not usually considered an eye infection, even if you have eye symptoms. The SARS virus is infecting the respiratory system, but also the vasculatory system. And so because of that, we're ending up with all sorts of weird symptoms. There's COVID eye, there's COVID feet, where people are ending up with weird inflammations in different parts of the body. And of course, in the eyeball, if you have an inflammation there from a virus, it can lead to secondary bacterial infections. I don't know if that has a name other than COVID eye. I'm sure some people are investigating it, but it is possible. All right, so that is the end for today. Thank you for coming out, and thank you for coming out at last notice to the online thing. Sorry about the change in venue. I should be back in person on Tuesday, no problem. We'll see you then.